Okay, well, let's get started with tonight's webinar. Good evening and welcome. Tonight's webinar is on the topic of behavioral health. And I'm Rick Walk. I'm the Community Economic Development Director for the City of Lacey and the Project Manager for the Lacey's Work Group on Homelessness. Now, the work group comprises of a diverse group of 30 Lacey community members appointed by the Lacey City Council with the charge to listen, learn, and discuss the issues of homelessness and develop recommendations for the City Council to take in response to the issues of homelessness in our community. So thank you again for joining us for the second in our series of informational webinars on topics related to homelessness in Lacey. Now, due to the COVID-19 pandemic and the inability to meet in person, we decided to create the speaker series to support the work group's efforts to gather information throughout the 12-month community-driven process that they are undertaking to shape the recommendations they'll make to the Lacey City Council. The webinars will feature subject matter experts from our region who will discuss current conditions, provide insights to the services available, and offer a variety of perspectives on topics ranging from behavioral health, funding, services, housing, and more. And again, today's webinar topic is behavioral health, and the panel will provide an overview on the issues of mental health and addiction in our community and the current service system that is in place and how it affects those that are in-house. So with that, I'd like to welcome and introduce our panel of speakers. So first we have Katie Strozik, and Katie has been the opioid response coordinator at Thurston County Public Health and Social Services since July of 2019. In this role, she has supported the Thurston County Opioid Response Task Force and the implementation of the response plan. This is a cross-sector effort to address all aspects of the opioid epidemic and related impacts of drug use, from prevention to harm reduction to recovery. So prior to her current position, she was doing similar work in Lewis County, which included the creation of the Lewis County Opioid Response Task Force and a medication-assisted treatment program in the county jail, among other things. She is currently finishing her Master's of Public Health at the University of Washington. Our second panelist is Brandi Clinton. Brandi is a mental health therapist and psychiatric medication bridge program coordinator with Providence Community Care Center. She has worked with the Providence system since 2006 when she started at Sacred Heart Hospital in Spokane, Washington. She has worked for Providence in Spokane, Portland, and now Olympia. She has spent most of her career working within the emergency department, providing psychiatric assessments and crisis intervention, and then also worked in inpatient psychiatry, as well as managed the Providence Intensive Outpatient Program here in Olympia. She has been with the Providence Community Care Center since we opened in September of 2017. And our third panelist tonight is Heather Krantz. Heather is a licensed mental health and addiction counselor, and she has worked for 2 years at the Behavioral Health Resources with the homeless population at the Community Care Center in downtown Olympia. She has also worked at the Olympia City Jail and Thurston County Jail providing mental health counseling. Now she is supervising a program for the chronically mentally ill with psychotic disorders and long histories of homelessness, hospitalizations, and incarcerations. And she also serves on the board for Coyote Village, a tiny house community in Olympia. So again, thank you everybody for joining us today. And thank you especially to our panelists and the expertise they'll bring to the work group discussions. So we'll start this webinar with an overview from each of the panel members. Each will have about 10 minutes to talk about their experiences and their roles in their particular organizations and in the community. We'll follow that through the question and answer period where the attendees, the work group members, can submit questions. And please submit your questions anytime through the question and answer tool on the bottom of your screen, of the webinar screen. And so during the question and answer period, I will read through the questions questions submitted and ask them to the panel. So again, just to reiterate, please feel free to submit any questions at any time as you think of them, and we will track them as we get to the question and answer program. So with that, we can get started with our speakers. And so, Katie, would you like to lead us off with tonight's presentation?
Sure, thank you, Rick. So thank you for that great introduction. I'm Katie Strozik, and I'm the Opioid Response Coordinator at Thurston County Public Health and Social Services. So my role is really to support the task force as a whole, as well as the specific work groups that have come out to work on the different subject areas of interest within the opioid response plan. Thurston County declared the opioid epidemic a public health emergency a few years back, and so we've been working on programming and setting measurable goals in order to address the opioid epidemic since then. We're a cross-sector group as a task force, and we've set SMART objectives. So those are going to be measurable goals with timeframes attached to them. So things like being able to achieve X amount of trainings by December 2020 and things like that. We've broken the task force down into different subject areas. So we have 6 subject-specific work groups. We've got pregnant and parenting, overdose education response and naloxone distribution, access to treatment, data analysis, prevention, and then criminal justice. So we really have a wide array of programs and projects that we're working on. Each work group is responsible for setting their own goals and then looking at how projects can best be implemented across different agencies within the community. As you guys have all felt within your own organizations and your own lives, we've of course had some flexibility this year due to COVID. Our plan stayed the same, but we did have to adjust things to be virtual or to push out timelines. A lot of our original plans were to do community-based trainings and education and things like that. So to talk to groups like you all tonight, but as we've seen, this has all gone virtual, and at public health especially, a lot of us got pulled aside to do different things related to pandemic response instead. So it would be really easy to focus on the types of programming that we're bringing to Thurston County, or the robust programming that already exists in our amazing community. But rather than focus on what already exists, one of the overarching things I really wanted to focus on tonight is the stigma and the barriers that we encounter really across the board for each of our work groups. So rather than diving too deep into one subject area, trying to find the overarching themes that kind of create issues or help us out when we're looking at substance use and the houseless community in Thurston County. The big one I wanted to address off the bat, I know I work closely with our homeless coordinator at Thurston County Public Health, is that drug use and experiencing homelessness are not synonymous. Using drugs does not mean you're homeless, and being houseless does not mean that you're a person who uses drugs, and really working hard within the community to make sure that that education is out there, because a lot of the community fails to understand that those do not always go hand in hand. And then specifically with the houseless community and within working in our work groups, trying to debunk the issue that people have to not be using drugs in order to deserve housing, or to be moved into any type of housing resource. That's one barrier that we encounter a lot when looking at different issues. Is it's really hard to get someone housed when they're actively using drugs, because a lot of programming and a lot of housing options state that you have to be clean or be completely ceased of your drug use prior to moving into such housing units. Or you move in, and if you begin using drugs again, you immediately lose your housing, which can put you back to the beginning of the cycle and cause a lot more barriers than you had to begin with even. As well as with stigma, I know that each one of our groups, especially criminal justice specifically, is really met with the idea that all of these services exist, right? We have a robust treatment network in Thurston County. We experience many barriers like other counties do, as far as delays in being able to access treatment, availability, things like that are so-called normal in the treatment world, having to wait for appointments and things like that, which Brandy and Heather will be able to talk to more about as far as direct service. But people fail to address the barriers that exist with accessing service. It can be really hard to go to detox or go to treatment. You may be ready to go to treatment, and it may be a month out from then. You may be ready to access a service, but you may need an ID, and an ID is $5, $10, $15, and you don't have the $5, $10, $15 to access that ID to even take the next step. And a lot of people have bad experience with treatment, honestly. treatment of all different sorts. It may be that you accessed medication-assisted treatment before and you didn't like it. So when somebody comes at you again and says, hey, I have medication-assisted treatment available for you right now, you may not want to take it because it didn't work for you in the past. You had a bad experience. It wasn't what fit for you. And then also, just because you access one service doesn't mean that that is the end all be all and everything is good. Normally, once one person accesses a service, it just means that there are 10 more services that they're going to have to access after that. When you're looking at the houseless community, especially the drug using houseless community, it is not a one step into getting someone to cease or reduce their drug use and get them housed. It is getting an ID, getting court fees set up, maybe dealing with warrants. It's getting a housing opportunity that's the correct fit. It's finding housing availability, which is really hard in Thurston County in general. Maybe dealing with things like past felonies, sex offender violations, all things of that nature. There may be family reunification. It's not as simple as being able to walk in the door, get an appointment, have all the transportation in the world, and then be able to obtain that housing. And then also the stigma that everything is a choice. It's definitely not that simple. I know that on my best day, it can be really hard to get to a doctor's appointment. Like an 8 a.m. doctor's appointment on my best day, it can be hard to not be rolling in there at like 8:02. I have the privilege of having an alarm clock and having a place to sleep and having reliable transportation to get there. That doesn't exist for everyone. So something as simple as being able to go to an appointment on time is just a huge barrier in itself, which then snowballs into effects on how other things impact your life. So 10 minutes is a really short amount of time, so I'm going to try to cram in a lot all at once. I sat in a lot on the City of Olympia's process of doing this, and there's a lot of conversation across the board with strategic planning and response planning on how you measure success. How do we know we did a good job? How do we know we did the thing, right? I know with homelessness and drug use specifically, people talk about ending homelessness or ending drug use, combating the opioid epidemic, ending the epidemic, and just really wanting to emphasize to you guys to set kind of goals that you can actually meet and not an arbitrary goal of ending a problem in a community or seeing things as a problem. There are houseless communities. It is not a problem. It's a problem that we don't have the correct resources at the right time to meet the need of our entire community. So success is not going to be immediately having everyone be housed magically. Success is going to be able to have the right resources that are available and accessible when an individual wants them. And then kind of looking at as far as the last year and a half on what I've seen in Thurston County, and then for the few years prior in Lewis County, what's worked and what doesn't work. Person-centered approaches work. Listening to what people need. I know that it's really easy to say that on meetings and it's really easy to put that on paper, but asking people what they want, asking people what their goals are. When you're looking at moving individuals into housing, ask them what their housing needs are. Housing looks different for different people. Not everyone wants an apartment. Somebody might want to be in their RV. Somebody might want to be in their tent. Somebody might want to not live alone and to live in the community that they've established. And that's a really big part of making sure that somebody can be successful, is being able to listen to that individual, the goals that they've identified, as well as the needs that they're identified. What you think their goals and their needs are may not be their goals and their needs. They may not want to stop using drugs at that time, but they may really want to get a job and get housed. So finding a way to maybe reduce that drug use and find other ways to meet those needs, and then circle back to things later on. And then I know you guys talked to Mitch and Lacey PD last week. So looking at things that are non-coercive programming and things that are not contingent on other things. So looking at having a resource like Mitch that is not a police officer, being able to go into communities is awesome. Essentially anything where you're not going to be punitive towards an individual exclusively for their drug use. When you're punitive towards just possession or using drugs, you're creating another barrier towards housing. By looking at an individual and saying, you have drugs on you, we're going to arrest you. What people don't realize a lot of the time is you're putting another thing on that person's criminal record, which is going to potentially show up when they go to get housed in the future. It's really hard to get people housed the more things that they have on their record. It may be then that you're displacing them out of their current situation. They may lose an ID in the process. They have another felony on their record. These are all barriers which are going to make it harder for them to become housed in the future. Before I run out of time, looking at housing really being a spectrum and a continuum of options. We look at recovery as being a spectrum and a continuum, just as we would housing. There's not a one size fits all box. So it is not you use drugs or you're in recovery and you're clean. There's everything in between as far as harm reduction. There's ceasing your drug use. There's using drugs in safer ways. There's using different drugs. There's medication-assisted treatment. There's talk therapy. There's everything in between that can be really successful for an individual and where they're at in each step in their life. So talking about housing in the same sense. So looking at things like some people need emergency shelter, so they're not sleeping out in the snow that night. Some people need safe parking because they have an RV and that works awesome for them, but they need a place to put it where they're not going to be towed. Some people need supportive housing because they have additional mental health needs or behavioral health needs, and they need that case management to be able to wrap around them. And then some people may need transitional housing where you can house them for now, where they look at getting a job, maybe ceasing their drug use, and then can move on to more permanent housing in the future. And then remembering all through this that individuals who use drugs still have personal autonomy and body autonomy, and that just like I have the right to do anything in my own life, I have the privilege of being able to do it in my own apartment where no one sees it, which is really awesome for me. People who are houseless are in the public eye constantly because they don't have this luxury. So being able to remember that everything we do, we need to remember that individuals have choice over their own body and what they're doing, and they also are able to set goals and achieve them themselves as we walk beside them on the way. And then I'll turn it over to either Brandy or Heather, whoever's going next. I know both of them have more of a direct service point of view than I do.
Thank you very much, Katie. That was a lot of information, and I'm sure we'll be able to dive in a little deeper in the question and answer portion. Brandy, would you like to talk about your experience with the care center and some of those frontline interactions that you have?
Yeah, absolutely. And well done, Katie. That's so much great information and content too to digest also. So I feel like taking a second just to be like, whew, that was a lot. So my name is Brandi Clinton. I'm a mental health therapist. I also am the coordinator for our psychiatric medication bridge program located out of the Providence Community Care Center. As Rick mentioned, a lot of my career has been spent in emergency medicine and providing crisis assessments, psych assessments, and crisis intervention. And really what drove my desire to participate in the community care center was the experience of working within an emergency department setting. And as most emergency departments across the country have experienced, is an inundation of patients with serious mental illness that may also have substance use disorders that are also unhoused, which also don't have access to adequate medical care. My experience in the emergency department, specifically in Providence St. Peter Hospital, was, we are an emergency department that has a capacity for around 40 people. And for approximately a year, most of my 12 to 14-hour shifts were spent having up to 20 psychiatric patients in an emergency department setting, with inadequate places to discharge them to or to admit them to. So when they were creating the Providence Community Care Center, what really spoke to me was that this would be a location where we had co-located services, including mental health support, access to substance use assessments, primary care, other emergency medical care, housing services, hygiene services that people could come in and start to participate in. What really was impactful about that is, kind of as Katie said, we weren't necessarily driving an agenda of everyone that comes in needs to be actively engaged in mental health services, does not need to actively have a primary care doctor, but they can come in and shower and wash their clothing and store their belongings so that they can go and interact in the community. And I think what matters really the most when you're developing programs, especially in the city of Lacey, because this is a slow process, because everyone wants to make sure they have all the information, is connection and education. And I think what's been really helpful within Olympia specifically is the ability for service providers within housing, within mental health, within medical care, is for all of us to really develop our own relationships so that we can better coordinate and advocate for the individuals that we get to work with. So being able to have an opportunity like this to come and provide some information and context to Lacey is a part of this more collaborative process, because what I've learned is that it's going to take an entire community. It's going to take a state. We all really have to work together and are responsible for how we start to influence and intervene with this issue, because my experience has really been about a lack of connection for individuals that experience homelessness, that experience serious mental illness, that get displaced due to domestic violence, due to childhood abuse and neglect and trauma that progresses into young adulthood, which may lead to substance use, which also leads to, mental health symptoms and homelessness too. And so I think that when you're starting to explore programs or how to best utilize the services and programs that may already be in that community, it's about increasing the connection between those service programs and the people that you want to serve. Let's see, I'm pretty pithy when it comes to talking about my experience, but what has really been helpful is that, I worked with Heather with BHR out of the community care center. This is how our program started to develop. And now we've developed this amazing professional relationship where people can refer to me and I can refer to them. And we already have this connection established. And the connection that we form as service providers increases the trust and credibility with the people that we get to work with. Because essentially, like I said, it is about connection and repairing experiences. A lot of people that are experiencing homelessness, serious mental illness, active substance use, have faced tremendous rejection and abandonment and negative interactions. They've been alienated from the systems that they've attempted to navigate, which we really push that you need to be able to navigate these systems to have success. And so when Katie talked about kind of coming up with sustainable, smart goals, how you really measure success might be in the connections that you're able to form within your community. So within the community of Lacey, how can you connect and partner with groups and organizations already there, already providing the services, and have them in a space that's easy to navigate without that necessarily agenda. So when we increase the connection, the rest will naturally progress and come. So with my experience getting to work out of the community care center, when we were open, I sometimes just hovered around individuals that were actively psychotic, also using methamphetamine, had been in and out of shelters, had been arrested on a daily basis. And sometimes it took just offering that person water or even sunscreen in the summer 8 months before they were willing to even consider trying medication too. So it is about putting the work in, and in terms of measurable goals, this is a process. And I think once people are willing to commit to and accept that this is a process and progress, then we can kind of temper the expectations and not be so quick to judge that something's not working inside of 6 months, inside of a year, that this is really just about improving how we connect with all people. So connect within organizations, having good relationships between our organizations, having good relationships with the people we serve. This is really how we start to role model coexisting and how we communicate with other people. And I know that was way less than 10 minutes, but that's my experience.
Well, that's fantastic. And thank you, Brandy. And so now we have Heather with their work at Behavioral Health Resources. And my understanding too is you coordinate from the front lines into those various service programs. So if you could speak about your experience and what you see in the system and the needs, it'd be greatly appreciated.
Let me know if you can't hear me. My webcam sometimes does not pick up, and I can get a little bit closer. Thank you, Katie, Brandy, you guys. As Brandy said, with the connection, it is so fun to be able to work with all the different service providers in Olympia, and we're really blessed to have a lot of programs that are doing good things. So I am a supervisor for a program called PACT. It's Program for Assertive Community Treatment. We are incredibly wraparound services for really psychotic folks. So we go out and give people their medications every day. We knock on their door, watch them take their meds, and we try and see them at least 3 times a week. I have a staff that consists of a nurse, a peer specialist, MHPs, drug and alcohol counselors, really diverse. And I start off with this because I think that what I want to talk about tonight is working with folks that are really psychotic, because a lot of the images that we see of people who are homeless is psychotic, talking to themselves, you know, and there's a lot of stigma and assumption of, oh, well, they're using or they're just high. So I kind of focus on just what my experience is of working with folks who are psychotic. So working on a team that is probably one of the most intense outpatient teams that you can possibly have, our folks still go to the hospital. And I think that that is the important thing for folks to know, is that even if someone is really well connected to mental health services, they have a chance of going to the hospital. What got them into the hospital may have been trashing their apartment. And if it's not supported housing, they may be evicted from that apartment. If they're not connected to somebody like us when they get out of the hospital, there is no place for them to go back to, and their resources are incredibly limited. Most folks who have a really chronic psychotic disorder are on Social Security. They make about $771, maybe $783 a month, which is not enough for rent, even if people were cognizant on their best of days to remember to pay rent. And there's not a lot of supported housing options. And every time that somebody has a psychotic break and gets evicted, they have almost no housing options, because even if you get a magic ticket of Section 8 and then you try and find an apartment, if you have an eviction on your record, they may not take you. I've seen so many people who had that golden ticket of Section 8. And for those of you that don't know, Section 8 means that you only pay 1/3 of your income. You still have to find an apartment. And if you have these histories of, like Katie said, felonies, evictions, arrests, you're not going to be able to utilize that. So the other thing that we do experience is, even when folks get off the street who are psychotic, we see them returning to the street a lot, because that's where their community is. Because how many places happily accept somebody who is baseline psychotic? And that's the other thing that we need to understand about psychosis, is when my folks are doing their absolute best, when they are fully medicated, when they are fully engaged in treatment, they often still have delusions. They often still have psychosis. Some of them are still talking to themselves as they're walking down the street. And that does not mean that they are high. It doesn't mean that they're not doing well. And this circles back to what does success look like for me, that is still success for this person. But unfortunately, there's so much stigma around psychosis that it's really hard to build community. These, you know, often they're getting kicked out of stores, out of businesses. There's an assumption that they're homeless, even if they're not homeless. If you are homeless, then that stigma increases 3, 4, 5-fold if you're sleeping on somebody's doorstep. And so a lot of times they're returning to the only community that will accept them, which is the houseless community. Also within that, because they are so vulnerable, they're often exploited. And so even just a little, little bit that they do have gets taken. And so the biggest part of this that I think is what I want you to understand too is, so say somebody goes to the hospital because they're having a psychiatric crisis, and they get out and they're homeless, and maybe they can't go to the shelters because they're too paranoid. There's too many people there. There's too much going on. Beds are stacked really close. And the way that I like to think of schizophrenia is, it's like if you didn't have a filter. So like, if you were walking down the street, you hear every conversation, you see every car driving by, you have no way of filtering out what's important and what's not. So loud noises, bright noises, conflict, all of that is really triggering and terrible for somebody who does already hear voices. So a shelter might not be an option. So then maybe you're staying in a tent, and then your meds get stolen, and then you don't have your meds. And decompensation without psychiatric meds is really fast. I've seen people go completely psychotic within 3 days. And that goes back to, again, as humans who are housed, how often have you missed your medication? How many times have you maybe traveled and then forgotten to take your 3 days of meds? Imagine if that resulted in a massive loss of touch with reality, maybe in a place that nobody knew you. And no one is going to help you because they perceive you as scary. So this is the experience that a lot of our psychotic folks that we see, on the streets have, is that they may have had a home at one point, they might have been in an adult family home at one point, but in that loss of connection with reality, they've ended up someplace else. They don't have connection to their meds. They are not cognizant enough to be able to go call, make an appointment with a mental health provider, wait the week to get in, go into their assessment, wait another month to be seen for psychiatric medication, and then, engage weekly with their therapist. It's not feasible. And we're a small program. We only serve 50 people at a time. So, we are not the end all be all. I don't want to pretend that PACT is the answer, because it's not. For me, what the answer is working, kind of like Brandy said, with all of the connection. We need our outreach teams, like Crew, like Familiar Faces, like Katie said, like Mitch, who are going out and connecting and just circling and being aware of folks. Because again, this population is been exploited. They are used to being kicked out of any place they go. They are used to being hated every place. Everyone that sees them looks away from them, avoids them, has this huge stigma. And so the way that you start engaging is by just being present. And like Katie said, Dana, what do you need right now? Is it just a cup of coffee? Is it, a place to park your RV? What do you need now? Because if people can't feel safe, then they cannot move into a next stage of mental health treatment. And so the way that it would sort of work in an ideal world is that there's the outreach workers that are like Brandy. So she can get someone in for medication bridging very quickly. So that gets them on meds, for a month or two immediately. That will help stabilize them drastically. And if she can kind of keep touching base with them, now they have a familiar face. They have somebody to go to of, okay, well, it used to be, I just need a bus ticket. Well, I could just drop them at the community care center. I know they'll give me a bus ticket. But when you're getting that bus ticket, you can also say, did you take your meds today? Do you need more meds? Do you need to see the doctor? What do you need today? And that starts to build that rapport. And then eventually they can get to sort of my point, which is holding on to, a little bit more stability and helping them get stable. But to echo, I think, what I've heard from both the other speakers, this is a process that takes time, and people will fall out. Just because someone is hooked up with services and falls out of services is not a failure. So for psychosis, every time that you have a full psychotic break, you lose a little something. A lot of times your baseline drops. You don't always come back. And so every hospitalization that we're able to prevent, no matter how small, makes a big difference. Every time that we are able to connect as service providers with the folks that need it the most, that makes a big difference in their life. And what is going to allow people to connect with mental health services and addiction services, they're sort of one and the same, is that connection to just sort of a friendly resource that is not telling them what they need to do, and safety. And this is what I always keep coming back to, is you cannot recover from a mental health illness or from drug and alcohol abuse if you do not feel safe. And it's really hard to feel safe without a place to live.
Right.
Again, just kind of picture in your mind, not having a lot of us are stuck at home during this pandemic, right? We're getting a full taste of what it's like to never be alone. And if you think that it's hard not being able to have your significant other go to work or have your kids not go to school, imagine literally not ever being able to be alone. And now add that a lot of times you've been in really scary situations. So now not only are you never alone, but you're always on high alert. And I won't get into the science of it, but it does really terrible things to your nervous system, to your amygdala. And there's actual studies that show that folks who have PTSD, when you show them a series of faces of someone just speaking like I am, they're more likely to peg them as negative, angry, upset, aggressive. Whereas if you show them to somebody who doesn't have PTSD, they might say happy, normal, calm. So we're working with a population that is incredibly traumatized, which means that they're seeing everything is a threat. And so we have to come to them and we have to build their trust. And that's on us. Instead of this idea that they need to fix their lives and pull themselves up by their bootstraps, we need to be coming to them on their terms, in their way. One thing that I always recommend to people, I don't know how many people have listened to the podcast Outsiders by KMKX. It is focused on Olympia and Olympia's homelessness crisis. And I do feel like it does a good job of giving some context. So if you're interested in sort of digging into that, I'm going to shamelessly plug them because it's great.
Great. Thank you, Heather. And that's a great plug with the podcast of Outsiders. And we do have that posted on Basecamp for the work group. So what we've done with this online, because of course we would like to have this type of interaction in person so we can have a dialogue and a little better flow. But we are using the web platform of Basecamp to be that kind of communication with the work group. And so we have on there a lot of different types of resources that they can access and comment on. One of them is the Outsiders webcast. And then another piece that we did is, and this is just to remind the work group members too, to go in and listen to these interviews. We've recorded or written interviews with people that are in the unhoused community, using some of our local partners to have a relationships built out. So we have interviews with folks that are in encampments or in RVs or in shelter or along the continuum of housing too, so they can kind of get a perspective of what those experiences are like and what are some of those either goals or challenges that they are experiencing. So thank you very much. That is an important plug. Does anybody else, just before we get into question and answers, anything else that you might want to take a minute or two to add? Seeing that as a no, we'll kind of jump into some of the questions now. And one question I did have, and this was something I've heard through, I think Mitch even talked about, but that the need to develop those relationships, and that can be a long process. And and Katie, you talked about there's so many different programs, and all three of you talked about all these different programs and service providers. And one of the challenges I think was identified that in creating those relationships and partnerships, how do you ensure there's one that they don't get dropped? Because I think it was said that if somebody doesn't follow up, then you lose a little bit of that trust of the system. And so how do you track people accessing services and being able to make sure that there is some follow-up?
In terms of follow-up, there's a couple of different platforms that, like Mitch uses through the Community Action Council. They use the RAGIC software for the master list for individuals in the Thurston-Mason counties that complete coordinated entry. And so as providers in the community, we have access to that master list. And so I know for my own practice, I utilize kind of cross-referencing individuals that I'm seeing with the master list for the coordinated entry program, my own Epic software for the electronic health record. And then we also partner with the Olympia Free Clinic as well. And so I can utilize their electronic health record too, to get a bigger picture of where an individual is kind of interacting within the system too, and also get a better sense of where do they need to go. If I am referred somebody, I check the master list to see if they've completed coordinated entry. And if they haven't, then that's kind of in the back of my head to maybe ask around that when it seems appropriate when I'm interacting with someone too. And so, vice versa, sometimes with Heather and I, we may have mutual clients or may have had mutual clients in the past. And so it's nice to be able to check in if I have an individual complete a release of information to say, have you interacted with them in the past too? So, getting to use electronic health records and also the RAGIC master list is at least how I track individuals, especially if they're representing to the emergency department. So then we can kind of see who may be frequently using that and try and better steer that too.
Great, thank you. Heather, do you have something to add, or?
I was just going to say that the other thing is that you can always ask the individual. I mean, a lot of times you can say, hey, have you ever had have you seen a primary care? And they'd be like, oh, I might have seen somebody, I think it was the one on Martin Way. And you're like, does Valley View sound familiar? And they're like, yeah, Valley View. And you can be like, cool, do you want to call them together? Do you want to call them right now and see if you're still a patient? Do you want to see if you need that? Or the same thing, they might be like, I don't know, I was seeing somebody, I don't know who she was with, and you can kind of dig and be like, well, what did she look like? Where did you meet her? What, and kind of help figure it out from there. Because people know their service providers, they just might not know if they're still enrolled in services or how to connect again.
Thank you. This next, go ahead, Katie.
I will say too that with Brandy and Heather talking about really interpersonal relationships between agencies to facilitate success for participants, agencies know what other agencies show up at the table. It's showing up at the table. It's showing up consistently. Sometimes it's bringing funding if you have it available, and it's bringing an open attitude to collaborate. So when you're talking at that higher level, when there's a common goal that wants to be accomplished and everybody sits down and agencies look around and see who's not at the table, it makes the relationships between those sitting at the table a lot stronger. So when you're talking about when you have a client come in and you're looking at who you're going to refer them to, it's, okay, I've had 6 months of working on this issue. I've seen this agency has been right here talking to me the entire time, figuring out how our referral system can be more cohesive, how we can collaborate better, how we can reduce communication barriers, how we can create a collaborative care team. And I've seen agency C has never shown up to a meeting or has not returned an email. It's really hard to create cohesive community partnerships and cohesive systems that work for the participant the most when not everybody's at the table, unfortunately.
Great, thank you. This next question came in from one of our members, and I think it came in early and maybe part of your presentation, Katie. It's, how do you balance the needs of the housed residents in our community for safe and healthy city lands with the unhoused residents and the challenges of either negative behaviors or some of those other impacts too, with refuse and litter and those type of things?
So I will start with that one if it's okay with Brandy and Heather. Okay, so balancing the needs of housed residents versus unhoused residents' needs, specifically safe and healthy lands and then negative behavior. I want to kick it off by saying what may be the unpopular thing is there is a difference between unhealthy and negative versus feeling uncomfortable. Everybody has a different norm, and there is a difference between somebody doing something that is negative or harming either to individuals or a population or the land, specifically the environment, versus someone feeling uncomfortable because someone is doing something that's outside of their norm. So when Heather's talking about somebody having a different baseline because of psychosis, that individual may be downtown Olympia yelling as they're walking on the sidewalk. That doesn't mean they're doing anything unsafe. They may be walking on the sidewalk yelling. That could be a good day for them. Just because I'm walking on the other side of the sidewalk and I don't feel comfortable with them yelling, that doesn't mean that they're doing anything to harm my safety at that moment. There is also a really big difference between that and behaviors such as theft and burglary and things like that. And I want to make sure that people understand that a lot of times these actions that are seen as negative behaviors or even criminal acts are because of an unmet need that's underlying. If you don't have access to certain things, you're going to engage in behaviors in order to meet your needs. So if you think about it, if you don't have shelter, if you're sleeping outside, if you have no source of income, if you have no access to food other than the very small window in which there's access to meals every day, you're going to participate in behaviors which meet your needs at that time, and being able to create a more robust system which is able to meet the needs that individuals have, those self-identified needs, as we talked about earlier, reduces those so-called negative behaviors from existing. So when you're able to connect individuals to employment or connect individuals to environments where they feel safe, they're going to be less likely to engage in behaviors which then touch other populations to create that unsafe environment. I know that as somebody who lives in an apartment, yet works in drug use and the houseless community every day, at no point in my day do I wake up and say, my goal is to feel unsafe today. No, No. But I do understand that individuals engage in behavior because there's something underneath. There's something that we're not seeing. I may not understand what that individual is going through that day, and they may be doing something because what we're offering them as a community is not right. It's not the right fit. And instead of blaming that individual for engaging in behavior, we really need to take a step back and say, okay, our system is failing this person. What can we do to better have our system fit the needs of this individual so that this behavior ceases to exist?
Great. And I think we have another question too along that lines, and that I think you just answered that, which is the feeling on what is your feeling on what our fear of the homeless should be feeling safe. And I think you just addressed that question, but also Brandy and Heather, I'd like to offer you the opportunity to add anything you think might be added.
Go ahead, Heather.
I think the big thing for me is, there's so many stuff like this that I just kind of put in the context of, that kind of what Katie said of like, what is the fear actually, like, what are you actually afraid of? Are you afraid that you're going to get attacked? Are you afraid that you're going to be stolen from? Are you afraid that you're going to have just a confrontation, even if it's just a verbal one? And I guess thinking about it, the folks who are on the street are so much more likely to experience violence than folks who are housed. Mm-hmm. And I think the best thing that you can probably do is to just, get some education around what mental health crises look like. I strongly recommend there's a course called Mental Health First Aid, which is just for lay people to sort of recognize a mental health crisis and recognize and know the resources available to you. And I think that there's no harm in removing yourself from a situation, but ask the questions that Katie's asking. Is this an actual threat? Is someone at risk of getting hurt? And Mental Health First Aid talks about this too, like assess the situation. Is there an active crime in process? Is there an actual harm in process? If so, sure, law enforcement may be your best option. But just taking an extra minute to say, wow, I'm going to just take a minute and sort of see what's going on with this person. It seems like they're just kind of staying in one place and yelling, and they're throwing things, but it's not at anybody. It seems to just kind of be at their general vicinity, and kind of questioning, am I unsafe? Is anyone else unsafe? Okay, I think it's okay. Does that make sense?
Yes, thank you. Let's see. This is a question for Brandy. You mentioned people that you get to work with and referrals. Does your organization engage in outreach to the encampments, or is it a referral system that only?
So what is really awesome about the role in the program that I'm in is that I get to be flexible. And so initially when we opened, this was before COVID, there was a lot of the encampments around downtown Olympia because a lot of people were being pushed from the more rural areas or forested areas into downtown. And so a part of developing trust and building credibility is meeting people where they're at. And so I have done tons of outreach when there were the encampments. Now that there's the mitigation site, the Deschutes Parkway, over in the jungle area off of Martin Way and Henderson Boulevard, I've been to those encampments, and most of the time that was as a way to kind of immerse myself in the community that I was attempting to try and provide service to. I've worked within a hospital setting most of my life, and so I needed to go get educated and informed. So I have done that. Now with COVID, we're still offering face-to-face appointments in the clinic and doing our own COVID screenings. However, because I've developed a strong relationship with other community agencies that do outreach, Interfaith Works, PIPE, and with Sidewalk, a lot of their navigation team or foundational community supports will be working with individuals, building that trust, building that credibility. And then when there is a willingness or readiness to offer mental health support, they will refer people to me. And so oftentimes if people don't have phones, they'll coordinate having somebody come into our clinic space. Sometimes I just meet people, introduce myself, kind of demonstrate that I'm safe, that I'm not going to force an agenda on them, and then kind of work on building that rapport and trust. And so I get referrals from outreach people. And then in places and spaces where I need to with patients that I'm already established with, I will go meet them if they are in an encampment too. But I also see people in our clinic space with our psychiatric nurse practitioner.
Great, thank you. And next question that we have is, in the best case, how long does it take to return a psychotic individual to a stable behavior?
Every person is really different, and there's a lot of factors. Is it their first break? Is it their 50th break? Are they in a hospital setting that is working well with them? Are they, are they on the right meds? Do they have a good history with stabilizing with meds? Are they also using substances? Yeah, there's not a clear answer, but maybe the answer that you're looking for rather is, so the cycle that we see a lot of times with folks who are psychotic is that, they either quit or stop their medications, and then usually within a week or a month need to be involuntarily hospitalized. When they're then in the hospital, that's the time in which they're sort of getting back on their meds and coming out stable. So maybe more of the question is like, how long are people staying stable, or what does that kind of process of hospitalization look like? And it's useful to know that a lot of times hospitalization is the only way to get somebody back on track when they have a psychotic disorder. It just reaches the point that they're so separated from the reality that we're living in that it's hard to have conversations like, you need to get back on your meds, or the delusions that surround the meds just happen, and so it's almost impossible to get somebody stable again without that hospitalization.
And I think also, if I can piggyback off of that, is kind of what Katie and Heather have also spoken to, is somebody's ability to be in a safe environment. Their perception of safety in an environment will improve dramatically their ability to return to whatever is a more healthful baseline. And so if we can create safety through our connections that we form with people, and security that way, if we can have someone develop some awareness around symptom recognition of, I see myself, or I'm getting feedback from other people, our ability to make observations sometimes cues people into where they're at. And if we have the trust built that somebody feels comfortable at least asking us for help, but they may not know what that intervention will look like, that is a part of that success piece. Is we need to increase people's capacity to actually ask for help, and then be able to be consistent with our responses there. And so if we can avoid the emergency department, that's where my program comes in, is to try and divert away from that and create that continuity of care too, so that people aren't being continuously put in an environment that's always changing, where they're exposed to even more trauma in the emergency department setting too. So we're reducing the stigma around that also.
Great, thank you. So our next question is, how can we help community members see and appreciate the challenge is complex, and that they might also be contributing to the problem they seek to solve? That's a pretty...
I think that takes such great responsibility.
Yeah.
Because if we take responsibility, then that's how we can influence the situation too. So increased awareness, increased education, the mental health 101 at the community care center, we provided outreach with different educational groups on a monthly basis too, where people can come in, ask questions. Heather and I presented on mental health basics for that too. And so I think the more that you can expose people to the information that they need to absorb and digest more frequently, it will become this unconscious competence, and this change will occur. And that's where all of these conversations on an ongoing basis will really do that.
Great.
I think for me, like, I tend to just kind of have 3 or 4 talking points. I've just in brief conversations with folks, just always staying really compassionate to their point of view. I mean, I have all of the compassion for folks that are impacted by people who are unhoused. We all want the same thing. We want to not have to be impacted by this. But like, for instance, I'll just have the talking point of, did you know that people who the government has deemed disabled make $783 a month, and you can't afford an apartment on that. And just that tiny little bit of education has changed a lot of people's perceptions for me, where they're just like, wait, what? That doesn't make any sense. I'm like, yeah.
I agree with what Heather and Brandy are saying. I think that anytime you hear, it's kind of like one of those like really cheesy things, but anytime you hear someone say something that's really stigmatizing or really perpetuates those misconceptions and you fail to say something, even the tiniest thing at all, you're just allowing that person to misinform another person who's going to post something on Facebook, who then it's going to get shared. And by saying any type of thing, even a little thing, especially if you can use data to enforce it, like what Heather was talking about, if you can stop that person and be like, hey, wait about, did you know about this? What about this? Did you think about this? It may stop that person from sharing that misinformation. That may be stigma stopped in its track that didn't spread to like 20 more people from there. And so really being the person who asks other people to take a step back and reconsider where they're coming from, rather than just being silent and letting it go forward.
So we have a question regarding the faith-based community. What is the one thing faith-based emergency shelters in our community do well, and what is the one thing they should improve?
Well, I think that the Interfaith Works does a tremendous job of inviting individuals that other places won't allow in. Due to behaviors, perception of negative behaviors, unhealthy behaviors, serious mental illness. They really do this gracefully within the community, and they really work hard to educate the community as well, too. So I think they're exceptional at how they work.
I would say that the faith-based community could do better in connecting with providers and members of the houseless community to find out what is actually needed. I think that a lot of times there's a perception of like, well, just socks, or maybe we can do a food drive. So maybe connecting closer with providers to find more effective interventions.
I don't have the same type of experience as Brandy and Heather do in this standpoint because I don't work directly with participants who are going to be accessing services. But I agree with Heather in that faith-based organizations, they do a lot, but they really stick to the status quo. It's blanket, socks, meals, and then sheltering individuals who are, with the exception of Interfaith Works, honestly, most other faith-based organizations locally stick to kind of the lower risk individuals who are houseless in order to shelter them. Interfaith Works goes above and beyond and picks the people that can't get sheltered elsewhere. But as far as the traditional faith-based community, but also at the same time, I really want to applaud the faith-based community because looking at a funding world, and especially in a governmental funding world, that's where a lot of our homeless housing dollars come from. The faith-based community, they pull money out of just thin air to do anything. That is the only community I've seen really that they develop a project and don't ask for help and magically can fund it themselves the next day, to an extreme level, just from the compassion that they have within their own community, which is astonishing.
I'm going to ask one of my question, or maybe some clarification, because on this theme, and in Lacey, there are a few shelters, and primarily they're faith-based operating shelters, not a lot of services. And there's a lot of concentration of services in downtown Olympia. And there's been a lot of discussion about spreading that out or concentration because you have everybody in the same proximity. And do you have any thoughts on what the challenges may be of either diversifying and spreading out those services, or is there advantages to spreading out and diversifying some of these support, either with shelters or supporting services?
I would say that just starting with that there is not enough services, period. And I do not think that Olympia alone can support the need for services. And that's a wide range. That's not just shelters, but like RV parking, to try and have Olympia bear the brunt of Tumwater, Lacey, and Olympia's folks who are unhoused that would be almost impossible.
There are enough people who are unhoused just within Lacey that putting up an entire shelter system in Lacey that also collaborates with other jurisdictions, but who serves Lacey primarily, it's not going to duplicate services. It's going to prevent the handful of individuals who are able to travel from Lacey to Olympia right now to access services from having to do that. But there is a whole lot of individuals who are unhoused in Lacey who aren't able to access any services simply because they're only focused in Olympia primarily right now.
Thank you. I'm going to take a pause real quick because we're just about 5 minutes over our 7 o'clock hour, and we have about 4 questions left. And I just want to ask our panelists if they want to continue responding to the questions that we have submitted to date. Is that okay?
Mm-hmm.
Great.
Mm-hmm.
So our next question is for all 3 speakers. It seems that unhoused individuals with psychosis and severe addiction issues are not a good fit for private housing because of the risk to landlords. What are the government-sponsored housing options currently available to you for locating patients or clients? I think it's a resource issue that you mentioned before, but what are some examples of those type of housings that would be necessary to bring online to serve your clients?
I'm going to try and answer this in the truncated, but I think the question is asking sort of what are the housing resources, and that's a very broad thing. First off, I don't think that it's unreasonable for folks who have psychosis to live in private apartment buildings. I have several folks who are living independently with no issues, and part of that is an understanding that the landlords know what is going on. A lot of times we have releases of information for the landlords, and they know when somebody is decompensating, who's the appropriate party to call. Also, again, there's the level of psychosis is pretty broad. There's folks that have been, their baseline is very low, and there is folks who are psychotic who you probably interact with on a daily basis and don't know who are holding full jobs and are fully functional. Second thing is that most folks cannot afford to live in private apartments. The only private apartments that are serving folks who are psychotic are places that accept Section 8. And that is definitely one of the issues, is that a lot of apartments don't take Section 8 because of that fear of property damage, of having folks who are, on Social Security and therefore disabled. The models that work really well are supported housing, thinking right off the bat of like Drexel House. So that's an apartment complex, but they have staff on site who can help, and case managers as well. And there's not enough of that at all. I mean, there's not enough of anything, but yeah, absolutely. BHR has a small amount of supported housing, but we are pretty much the bigger provider of anybody who has Medicaid, Medicare, and the tiny bit of housing we have is not even a drop in the bucket for the needs of folks. And I mean, it's affordable housing is disappearing for everybody, not just folks who are psychotic. I mean, it is, I don't know if you have seen rent or housing prices in this area lately, it is obscene. And even people with good jobs are having a hard time affording private apartments.
There are also, outside of permanent supportive housing, which is what a lot of individuals need, as far as the private landlord part, there's been a concept explored in other areas with a landlord mitigation fund, where an agency who has hands-on case management with an individual, most likely a high level of case management, they partner with specific landlords knowing that this individual may have eviction history, they may have a history of behavioral health issues, they may have a history of drug use, knowing that things like a damage deposit, which a lot of times you move in and you expect to get back, that may not be the case with this person. They partner with an agency who then participates in a landlord mitigation fund, from what I've seen from flexible housing dollars coming down from a county level in areas outside of Thurston, so that an agency partners with this landlord saying, hey, this individual's doing really great. They just need a place to move in and get a chance to prove themselves because they've got this eviction, they've got this. We are going to help. We're going to, make sure that dishes get done. We're going to make sure that there's not bunches of trash that stay and rodents come in. And then that landlord mitigation fund kind of acts as a buffer so that if this individual does get evicted anyways, or if this individual moves out and there's holes in the wall from a psychotic episode, or there's bugs because the individual didn't empty their trash, things like that, that money is there to provide those repairs so that that landlord has kind of this extra buffer to be able to be willing to rent to individuals who would not be able to be rented towards otherwise. But that's specifically for private landlords. Most larger corporations don't do that. And normally it's partnered with individuals who are part of pretty intensive case management services, like Heather's program, where they have somebody who is like, hey, it's been a week. Did you take that trash out? No? What are we doing? Can we help that? Do you need trash bags? What do you need in order to provide that level of security and trust for the landlord? Because they don't want their property to be damaged. But sometimes an individual just needs a chance.
I'm going to try to paraphrase this next question because it's fairly long. And so, an understanding the needs of the housing community, there's not enough service or service providers or access to services out there to help everybody right away. And but you also have the encampments and living that are quite visible. And how do you balance trying to maintain places for people to stay while they're trying to access services and dealing with that public perception and concern out in the community as what they travel and see see those things? How do you balance those two issues versus, some may think it's a crisis and some may not?
Greg, are you talking about the one that talks about public health crisis as far as specifically encampments?
Yep.
Okay. So
again, it's that perception of the community, what they see, and the need for services, and that intersect of what do we do in the interim until you have a robust system in place?
Yeah. So public health crisis as terms or public health crisis for the residents of the encampment versus public health crisis and perception for the community. To be point blank, most encampments are more of a public health crisis for those who are living there than for the community. There have been some cases in which there's some public health impact, but when you're looking at public health as a whole, encampments impact those who are living there. Environmentally, that can really be mitigated a lot of the time by supplemental services. So we're talking about encampments can get pretty large, and waiting for services to be stood up in order to meet the needs of all those individuals, from emergency shelter to cold weather shelter to supportive housing and all of that. That does not happen overnight. It does not happen in 6 months, but being able to provide services in order to mitigate the public health part. So in public health, we're talking about water, sewer, garbage, trauma, things like that. That's primarily going to impact the individuals living there. So being able to set up facilities with hand washing stations, with restroom facilities, with trash takeaway, that's a really important one. In order to not build up those hazardous waste issues in the camp itself, is the really crucial element. As far as public health impact on the community around them, most of that is mitigated when you handle the public health crisis itself. Because when you look at public health impact on the broader community, if you have restroom facilities available for individuals as in encampments, you're not going to have any type of sewage runoff. When you're able to have trash taken out, you're not going to have rodent issues and bug issues and wildlife issues on top of it. Can it be an impact on the community around it? Yes, definitely. Is it a public health crisis for the communities around it within an encampment when they're provided essential services? Not quite a level of public health impact as when those services are not provided, nor for the actual encampments themselves. I think also the issue why encampments are getting so big right now is because there's nowhere for people to go. And when people go somewhere, they get pushed out. We saw people camp or put their RVs onto chutes and get pushed away. People don't just go away. When we sweep camps, when we clear RVs, people are not just leaving Thurston County. They're not just magically not houseless anymore. They don't magically have income that they didn't have before, housing units and things like that, or family that can support them, you're simply just displacing them from one area to another. So if you take 15 little encampments and you push people out of 7 of them, all we're doing is pushing people to larger chunks of land and making them much more visible, which is exactly what we've seen on Deschutes. When we talk about public health and you're looking at Deschutes and the sewage and trash and the visibility of the individuals who are houseless right along the lake, it's because other smaller areas have been cleared and people got shoved there, and now people are really visible.
Great, thank you. Then with the services, with all your services, it's a question for all 3 speakers. Are you serving the Lacey population or only Olympia? I think you got kind of answered this with that dispersion of services and shelters question I had earlier, but just in case, are you serving the Lacey population or only Olympia? And if you are serving the Lacey population, what's the numbers look like? Is there I guess there is a desire to understand what type of numbers there are in Lacey, because there are some that are spread out throughout the community.
I think people are not sticking to Olympia as that's their zip code, or Lacey and that's their zip code. PACT, I work with all of Thurston County. And what do you mean by from? Did they stay in Lacey for a couple of months before their camp got swept, and then they ended up in Deschutes, and then that got swept until they went back to another place in Lacey? It's not like these 3 cities with Tumwater, we are not far apart. We literally touch, and my office especially, I think, is situated probably exactly on the border between Olympia and Lacey, and it's really hard to separate out which is which. But if you're looking for numbers, I might direct you towards the point in time count, which is for Thurston County, where you will make best effort to count as many folks who are unhoused as possible. I think that number was somewhere around 900 this last year, and it's usually significantly undercounted because, as you can guess, it's very hard to count folks who are unhoused. And so I would guess from that 900, those are mostly folks who are in Lacey, Olympia, and Tumwater. And with Olympia being smaller and less spread out, I would say the majority of those are probably in Lacey and Tumwater.
Thank you. Yes, we are having another point in time count coming up this January, and we also provide that information to our work group so they can volunteer. And then also we're collecting numbers too for North Thurston Public School District, because they do also track with their family support services the homeless population and student population and families. So we're trying to reconcile both numbers to kind of get a more accurate count, as accurate as you can get.
I will, in my shameless plug for the Thurston County Opioid Response Task Force and its work groups, I would love active and consistent participation from both Lacey PD and the City of Lacey. We meet every other month. We meet next January 4th. It is an open meeting. If anybody from the jurisdiction or the public would like to join, it would be great. We consistently don't have representation from all jurisdictions across the county, and it's something that is really important because as we talk about, things get really Olympia focused. And the only way to make it not Olympia focused is for people who aren't just Olympia to come to the table and be a part of the conversation.
Great, thank you. I got that written down, so I'll follow up with you on dates and schedules. I want to end with this last question because I like this question, came in early, but I thought it was a good question to end on. And is that if you can each take a minute or two just to share a great success story that you have experienced in your work with serving, those with mental or addiction or unhoused community members. And I'll let you who wants to maybe start first.
I can go first. We had kind of a new client to us at PACT, and she had been homeless actually in Shelton for about a decade. And we have her, she's housed and part of the PACT team. So we're, going out there every day, giving her meds. And one weekend she disappeared. And we were all like, oh, where did she go? And we were worried. And then she came back Monday and we were like, oh my gosh, where did you go? And she was like, oh, I went to Shelton. And we're like, okay, well, let us know next time so we can send you with some meds. But the next day, I got a call from the Shelton Transit Center, and it was somebody who had known this woman for a decade. And she was like, I didn't recognize her. I have seen her for a decade just wandering the streets, talking to herself, disheveled, a mess. And she walked in and she was smiling and she was beautiful and she was so happy and she was completely clear. And she was like, she has an apartment now, I hear. And she's like, I want to give her a TV. She said she needs a TV. Where can I drop this off? And I mean, for me, this was just like, this is how we're all connected, you know, that somebody who's in the transit center saw this woman for a decade struggling, and through the grace of being housed and being given good services, was able to reconnect with her and just be like, this is her at her full potential. This is her being able to live as she's at her highest capabilities, and that's beautiful to see. So.
I guess a great success for me, and I think that this is a little bit more tailored towards how we temper our expectations and measure success, is that I work with individuals with schizophrenia and also substance use disorder, very severe. And one specific individual I worked with for a couple of years, and he got referred to me because his sister had been bringing him food in an alcove downtown, and he was frequently arrested by OPD for possession charges. He'd lost the stability of his adult family home. He'd been off of his psychiatric medications for, I think, maybe close to a year. And I started just interacting with him briefly. He became open to restarting psychiatric medications. And so that was great. We can build upon that. Again, another individual that I would see every day and say, hey, here's this medication and let's see how it works, and just real kind of a gentle approach. We built upon that trust. I became a safe, secure person for him. And then we were able to kind of work towards trying out shelter, him even having a willingness to stay in a shelter. We tried that. It didn't work. He's had a lot of trauma and abuse. And as he's a 6'2" male, did not tolerate that setting very well. So we tried that. It didn't work. He's still sleeping in an alcove, still using substances, but taking psychiatric medications, and has somebody that he can come to for help. Eventually, one of the supportive housing apartments here in Olympia was willing to have him come in. They accepted him into an apartment where he lives independently. And here's somebody with very serious mental illness and substance use disorder who, maybe had a negative relationship in the past with BHR. But through my connection with Heather, he was exposed to Heather, and she became a safe, secure person, and he became open to transitioning to that PAC level of care, and is still housed now. And this took about 3 years. And so this is what success kind of looks like. It takes time and that connection and building upon that to improve health. And so that is what it looks like.
That's amazing.
I don't have cool, happy client stories like that because I don't do direct service. My big success is we do things like this now. When I started in behavioral health and started a task force in Lewis County, public health and community outreach workers and the police department and the prosecutor's office not only did not talk, but actively made it a point to not talk because we had different goals. In Thurston County, we sit at the same tables and we talk to each other. And when we email each other, we answer and we try to work really towards the success of the individuals of the community together. And some communities still are not at that point. And I think, honestly, we can attribute a little bit of it to COVID and looking at it. We're looking at ways now where we're acknowledging that we are not going to arrest our way out of individuals being houseless. We're not going to arrest our way out of individuals using drugs. It's not going to help. It's going to worsen the situation. And so being able now to be at the point where we're able to acknowledge that at a community level, we're able to all sit together with different points of views, but all want the health of the entire community to be at the forefront of our conversation. That's a huge success because a lot of places are not there yet.
If I can add something really quick too, especially along the law enforcement line of, opening in downtown Olympia, we've partnered a lot with the Walking Patrol and Olympia Police Department, and they've come up with their familiar faces and now Arrest and Jail Alternatives program. But something that changes is, like Katie says, having these conversations with other community members so that people can get better educated on that. If somebody has a drug problem or possession, maybe there's an alternative to arrest for that. And so public perception really drives procedures in law enforcement to arrest people. And what I've observed in the last 3+ years is that with Walking Patrol, when they may have interacted with one of my patients, hey, don't you have a housing thing coming up? Like, why don't you do that less, or something like that? There's more awareness, there's more reinforcement of positive outcomes and interventions being offered because we communicate constantly. And so if they know, hey, aren't you working with Heather? Aren't you doing that? Can I call her for you? That's really what's changing. That's what's happening.
Well, great. And thank you very much, Katie and Brandy and Heather, and for taking the time to share all your work and experience. And it is amazing the things that you all do in the community and serving the public, the individuals, and the in-house community. And again, I know that our work group members are really appreciative of the information and expertise you've shared tonight. And with that, I want to conclude. I see a couple of comments in there about appreciating all three of you with brilliant thinkers and doers and gratitude. So again, this concludes. I'm going to, since we're getting close to the 90-minute mark, I want to conclude this webinar because I think we can continue to talk about these issues and for quite some time. But I do would ask if there's opportunity in the future that if we can potentially, if there's a need or an opportunity to engage in you in the future, that I can call on you again to have a conversation. Who knows, maybe by that time we might be able to have some type of safe dialogue in person, which would be even more helpful. But again, I do want to appreciate all the time and energy that you have given us tonight, as well as your work in the community. And I offer, if you might have a 1 or 2 minute wrap up, if you wanted to share, that's this be an opportunity. If not, that's fine as well too.
I just want to kind of echo Katie and like how grateful I am to be here and that the city of Lacey is engaging in these conversations. And thank you so much for having us.
What Heather said.
Yeah, what both of them said. And the one thing is that it's going to take time. It's going to take more conversations. It's going to take more education. The expectation should not be to all of a sudden have this done overnight. It's not the expectation of the work group members also. So I value getting to have this conversation and be a part of it and appreciate everybody's time.
And as I mentioned earlier too, and you touched upon this theme, as this work group continues, we are going to have some open community engagement, and we'll make sure you're aware of those opportunities for our virtual open houses and because part of this process is not only to develop recommendations for council, but also to help inform the community of all the various complex issues surrounding homeless and mental health and addiction issues. So we'll continue moving forward and we'll keep you apprised of our progress. We do have the 5-year countywide homeless response plan. That's kind of the umbrella for the region. We have I know the city of Olympia has gone through this process recently with their one community plan, and now Lacey is working on this process to be, see what Lacey can come up with, as well as be consistent with the countywide plan and coordinating with the Olympia plan. So again, thank you very much for taking the time and all your service to our community. We appreciate it.
Thank you all.
Thank you.